Perfect. All right, start off by saying I have no disclosures. A lot of what I'll be talking about comes from two different bodies of work. One of them is the National Stress Fracture Registry, which was an online stress fracture registry which we ran in 2008, 9, and 10. It involved over 60, 75 athletic trainers from 16 different states, basically compiling information on various stress fractures that were occurring to the high school population. And also a study that we're currently working on at University Orthopaedics called the Validation of the Shin Pain Scoring System, which is basically taking information from the stress fracture registry. We've put it into a scoring sheet to see if we are able to predict whether or not kids have got stress fractures based off of a score. And we're currently in process of collecting patients for that study. So the questions I want to address today is what's the optimal clinical approach for evaluating lower leg for signs of injury, and how sensitive and specific are the current tests. Basically, when we're looking to evaluate shin pain, we know that we've got traumatic and non-traumatic. Traumatic injuries are more single incidents. Non-traumatic, there's no mechanism of injury, generally more of our overuse type problems. You have intrinsic. When we talk about non-traumatic injury, things we need to kind of be cognizant of or consider is intrinsic factors, like what are the factors that are directly related to the person: BMI, menstrual health, leg length, family history, bone mineral density, their hormonal status. Extrinsic things are more like changes in training, their equipment, training surface, faulty mechanics, sleep, rest, stress, and diet. Shin pain differential that I got from one of our physicians here, Dr. Swan, is he came up with a mnemonic he learned in med school called vitamin C. Vitamin C, as we're considering all the different things of the lower leg: vascular, infectious, trauma, autoimmune, metabolic, idiopathic, neurologic, and cancer. You know, just different things that you have to keep in your mind as you're doing an evaluation of somebody coming in your athletic training room. So shin pain. This is what my athletic training room looks like pretty much every day in the fall, spring, where they're lined up outside with their ice bags on because there's no more room in the athletic training room. There is just tons of it happening at the high school population. You on the secondary school athletic trainers Facebook page, and somebody had posted this, a picture of Oprah, and as soon as springtime came around, everybody was just like, oh no. It's just like shin splints, shin splints, shin splints. Here we go. Everybody gets shin splints. It's one of those things you just get tired of talking about. It's a huge problem in the secondary school. Okay, so the frequency of shin pain can be overwhelming. Good studies on the published literature, or good published studies and clinical tests are limited, but and a thorough evaluation of each of these kids that's coming in the athletic training room can be time consuming. Imaging can be costly to really work it up, but the net result oftentimes is, as athletic trainers and primary care physicians, we come up with a diagnosis of shin splints. I absolutely hate that term, and hope that we kind of put it to rest, as there's no official medical diagnosis for shin splints. You cannot image it on an MRI. It is not associated with a pulling away of the muscles, to the bone. It's been disproven in the literature, but yet it's a term that we as primary providers tend to use as this blanket term for everybody with shin pain. And I really think it's doing a disservice because it's such a run-of-the-mill, commonplace term. It gives you no diagnosis of what the actual problem is. Kids hear shin splints and they say, no problem, I can continue running and doing whatever I'm doing that's causing me shin pain. My track kids like to say shin pain is nothing more than weakness leaving the body. Pain is weakness leaving the body. Come on. No formal diagnosis, garbage term, can't identify it on MRI. It's highly inappropriate. Let's get rid of the term. Interesting finding: of 64 subjects that we had evaluated with 1 week of shin pain, doing x-ray and bilateral MRI, 58 of the 64 showed evidence of bony stress injury on MRI. It's a pretty significant finding. So all those kids that are coming into your training room, the vast majority of them have got findings on MRI. It's not just something that's happening extra-articular. This is bone marrow edema that's going on with these kids. 45 of the 64 showed bilateral stress injury. That's 70%. and 82% of them were grade 2 or greater. So we've got significant bony injury that's going on with these kids. Early detection's the key. So tibial injuries can be disruptive to a regular fitness routine, and they have been known to end careers of some competitive athletes because some athletes just never get over it. It's important to establish a diagnosis early so it doesn't go on to a true fracture. One paper by Nativ showed that each 1 unit increase in MRI grade increases recovery by 48 days. So going from a grade 1 to a grade 2 to a grade 3 to a grade 4, it increases disability. And Oda Fukushima published a paper where they looked at diagnosis within the first 3 weeks versus diagnosis after 3 weeks of the onset of shin pain, and there's almost a double length of recovery time if it's identified after 3 weeks. So it's important to take an early interest and to start a dialogue with your athletes. There's lots of different things that we need to be talking about because that shin pain that they're coming into the athletic training room may just be the tip of the iceberg. So lots of things we need to consider. History. In terms of mechanism of injury, we found from the National Stress Fracture Registry that kids coming in with a history of a stress fracture report a symptomatic or a pain rating of greater than 6. So as you can see kind of from the graph that if they've come in with a pretty significant shin pain rating, that you've got to be highly suspicious that they've got a stress fracture that's going on. Other things you want to note is numbness, tingling, prior treatment that they've had, and how does it impact their performance. Observation, we want to look at the skin, look for obvious swelling, discoloration, bumps, bruises. That's pretty much standard. Then we go to our clinical tests. Lots of clinical tests that you may not find in Starkey and Ryan, or you may not find in Prentice, but some things that we've been working on by doing our shin studies here. Clinical exam, palpation. I think it starts with palpation, and Dr. Coyle always taught me that it's good to use a good firm set of thumbs is important for being able to identify problems. So a good firm squeeze, palpate the medial edge of the tibia, the anterior spine, fibula, and sometimes it's helpful to take a marker or a pen and just mark the leg where they've got their tenderness, and you'll find that it may be good to illustrate the extent of what their injury is. Palpation was found to be a significant predictor of bony stress injury by Newman. All right, fulcrum test is basically you're using a force, kind of like a valgus force from the side of the leg. So grabbing onto the ankle and you're doing a lateral force, doing it at 2 to 3 different places along the lower leg. And it's a positive test if the patient expresses pain. Inner tester reliability is low. As we're finding as I kind of do this test, it's a pretty reliable test for me. As I have some of our other physicians do it, the inner tester reliability isn't always there. But when it's positive, it's usually pretty indicative. Tap or a percussion test. Use 2 fingers. Go along the course of the bone. If you find a suspicious spot, you may hit it 2 or 3 times and you're looking for tenderness. Just an illustration with a palpation. I'll take a pen. Oftentimes it's good too to use a pen just because it really illustrates to the athlete, the different spots. And it's funny how you have a spot on the medial side, on the anterior side, and then again on the same spot on the fibula where they may be having pain. Fulcrum test going from the side. And don't be afraid, you're not going to break their lower legs. So I usually give a pretty good stress a couple different points and go ahead and wrap it with the with the tapping. There's a shin oedema test which was published by Newman. Basically, you're using finger pressure over the medial tibia for 5 to 10 seconds. You're looking for pitting edema, and it's a predictor for later onset of tibial stress issues. Tuning fork, some of you may or may not have used. There's different frequencies for tuning fork. Basically, you vibrate the tuning fork, you put the end of the tuning fork over the point of the bone where it's most tender, and if it increases their pain, then it's a positive finding. So depending on the different vibration frequencies of the tuning fork impacts whether or not it's a positive finding or not. But Schneider's found in JOSPT that it doesn't support, the findings don't support using it as a standalone diagnostic test. But it may just be another tool that you're looking at to heighten suspicion. Single leg hop test, something that I came up with in our athletic training room. And you're asking them to do a single leg hop from their foot, try to get up on their toes, so it's not a flat foot hop. You're looking for increased landing time, decreased hop height, drifting, meaning moving all over the room as they're trying to do their hop, increased pain, and here's an illustration. Kind of flat foot hop, drifting a little bit, and I don't have the audio on, but she's like, yeah, that makes my pain worse. Drifting, kind of all over the place. So this one, some bilateral findings, kind of drifting all over the place, but look at more flat foot hop, increased landing time. Flat foot hop. All these had grade 2 or grade 3 stress reactions. Flat foot hop, can't hop. More flat foot. They don't get the plantar flexion, they don't get the push off. And you can see the increased landing time with their flexion. Flat foot. Kind of all over the place, and he's going ow, ow, ow the whole time he's hopping. So I think it's important to take time, really look at the clinical exam, and you can tell a lot of what's going on just by looking at the hop. And last one. Flat foot. Okay, we've also been looking at the weight-bearing lunge test to look at dorsiflexion, checking dorsiflexion of the ankle. Now it's hard if you put somebody supine on a table and you check dorsiflexion with a goniometer. There's a lot of variation in the range of motion, but when we do it with a loaded weight-bearing lunge test, it's been compared in the literature to accurately assess dorsiflexion range of motion. It's a pretty good finding. Let's see if I can get back here. This laptop's a little... Okay, basically she's going to do, we have a little ruler on the floor. We measure the distance from the toe to the wall, and they want to flex the knee, taking it to the wall, but when the heel comes up off the ground, as it does there, that's the end range of their motion. So as you measure the distance away from the wall, you'll find greater dorsiflexion range of motion of their ankle. So it's a nice little test to use, a comparative thing that you might consider. Therapeutic ultrasound, not diagnostic ultrasound, therapeutic ultrasound, using half centimeter, starting off at 0.1 working up to like 2 centimeter. Just basically slowly moving it over the area of the bone that's sore. If it gets an increase in pain, then it's considered positive for a stress fracture. Good number of studies. The variability lacks consistency of measure, but it's low to moderate sensitivity in terms of using it as a test. Standing heel rise test, I'll use with some kids as we're trying to look at, making the differentiation between compartment syndrome and stress fracture. And it's also, I'll use standing heel rise test, I think, as a great screening tool. That if you get kids to do single leg raising up on their toes, they can use just 2 fingers for support onto the examiner, and we put a metronome that goes basically at 40, so it's like 1 toe raise about every 1.5 seconds, and you do it until they get to the point where their pressure is more increased on their leaning, or their height decreases. You count the number of reps. And the healthy person, they found the number that they should be able to do is 25, and a person with shin pain, they bottom out. They've got very little strength when it comes to standing heel rise test. Nice screening tool. Something I want to look at with my track kids is looking at kids preseason, how many kids don't do well on the standing heel rise test. Standing heel rise test would give you evidence of weakness of your gastrocnemius and your posterior musculature. Manual dorsiflexion, dorsi and plantar flexion test is what I'll use for compartment syndrome. Sitting on a table, dorsi, manually resist, dorsi and plantar flexion for a minute, see if it increases their pain. Radiographic workups, plain radiographs we like to do to rule out frank fracture. And I know a lot of primary care people don't necessarily get the initial x-ray because the initial x-ray is going to be normal. The initial x-ray is only positive 5 to 25% of the time, and it's less than 50% positive in repeat serial x-rays over time. But sometimes you can see a periosteal reaction, cortical thickening, dreaded black line, and it's often used as, well, if you have a normal x-ray, many clinicians are saying, well, if you have a normal x-ray, you don't have a problem that we really need to worry about. But I think it gives you a false negative. But an x-ray should be done because of these things called bone tumors, which do happen. So manual muscle testing. Also want to look at just the basic strength of the other muscles of the lower leg as you're evaluating the leg as well. There's been some papers written on weakness of the external rotators of the hip, and that may be something you look at, particularly when you look at kids that have got chronic shin pain as well. That may be a consideration for your rehab. Summary, shin pain is common. Take time to evaluate. I think you'll be surprised at some of the things you find out. That shin pain is just the tip of the iceberg. In many cases, there's a lot of different things that's going on. So that kid that walks in there with shin pain, that's just the thing that they're complaining about that day, but there's many other things that may be going on, particularly with females when we talk about female athlete triad, eating disorders, menstrual issues, stress, sleep issues, dietary, intake issues. There's lots of different things that we may find. Clinical tests are not highly publicized or validated, but I think there is enough things that we can do clinically to try to pick up some more of these stress problems that we're seeing. Radiology is recommended initially, but avoid the false negative diagnosis because x-ray will oftentimes not be positive. And just remember that earlier diagnosis leads to quicker resolution. Common cause of shin pain, x-ray is important. Pain greater than 6 should be considered significant. And positive palpation and hop test is significant when you find it in your clinical exam. And earlier identification leads to better outcomes. Thank you.